It's a great pleasure to be here. So, we don't know what's most effective. But if we're going to tackle chronic disease, what we know is that this tendency towards increased focus on patient care, patient-centered care, is not going to get us out of the woods that we're wandering into, and population health interventions are needed. And secondly, that we cannot do population health interventions without paying attention to the social gradient of health, which means reducing disparities, tackling inequalities. And thirdly, that economic evidence that we have been talking about when we talk about bending the cost curve is insufficient, and exactly the type of work that Dr. Kruger has done is what's needed, and more of it. Why is economic evidence not enough? Well, I'm preaching to the choir here and talking about why health care and getting better health care, more efficient health care, is not what drives population health. Health care is just one part of what creates our health. A whole bunch of it is genetics, our neighborhoods, our incomes, our education, and our health varies over the course of our life cycles. So this pyramid basically says there's these multifactorial things that influence our health at any point in our lives, but what we're seeing are big population changes of the sort that Dr. Kruger has mentioned, and economic evidence needs to pay attention to the costs for sure and the benefits, but the costs and benefits need to be somehow amortized or conceived of over that 20, 30, 40, even 80-year time horizon, and we're not very good at that yet. There is an issue here when we talk about efficiency, and the big issue is equity. And this is a very old chart that talks about the health gradient, the social determinants of health that I mentioned. And all the risk factors that we're talking about are accelerated if you're poor, if you have less education, if you live in an isolated way, if you have terrible housing, if you are unemployed. We know this. The data is consistent over and over again. That gradient exists, so addressing the things that drive the gradient are just as important as many of the population health interventions that we talk about. And there's also a social gradient in health. I don't want to point this out because I think I'm going to be thrown out just like Dr. Kruger, but if you take a look at the average income per capita and per household across the nation, you will see a very tight gradient that goes along with incomes and health. And we see this as well. So so this is measuring ill health. It's worse amongst the poorest, which is at the left-hand side of your screen, and best amongst the richest. And that is true in every country, everywhere. And we'll see that life chances by income are also better. Your probability of surviving to 75, the age of 75, if you're living in a big city in Canada, amongst men are better if you're rich. Same with girls. These are the most recent data that we've got. And it's not just income, as I mentioned, other social economic factors. For example, your education in particular, but also where you live affects your health. So where you live affects your health. This is a chart that shows, this is quite old, 1990-91. And the big red blob at the bottom is Toronto. And below Toronto is a bunch of yellow dots, and they're all Sweden. And the further along you go, the more you have unequal distribution. The further along you go to the right, the more unequal is the distribution of incomes. And the further down you go, the better is your health. So there's a tight correlation between ill health and high income inequality. And this is 1990. We don't have anything like this that is more up to date. But as Dr. Kruger was saying, these things have a terrible lag period. And since 1990, Canada's inequality has grown at one of the fastest rates in the OECD. In fact, it is the second fastest rate of growth in the OECD, Sweden being the first, and Sweden fell from the first most equal to the third most equal. But we went from above average to below average inequality. So we have got a real problem. But it's not just what city you live in, it depends on what neighborhood you live in. There's a great report that was done by the Hamilton Spectator using census-based data showing, it was called Code Red, and it showed that there was a difference of 21 years in average life expectancy between the richest and poorest neighborhoods. And they described it as an entire generation lost between these neighborhoods, between the top and the bottom. And over time, what we know is continued income polarization, which we have been experiencing, leads to spatial polarization. So there's a map of Toronto in the 1970s, and the red area You can see three areas of high intensity poverty. The second one is in the 1980s. The third one is in the 1990s. And you can see that increasingly we're having pockets of high intensity of poverty. And this study by path-breaking work actually by the Center for Urban and Community Studies out of the University of Toronto shows that the middle area is middle-income neighborhoods. So the average income of these neighborhoods is middle income, and they're measured by 5 different income slots, so very poor, moderately poor, middle income, moderately rich, and rich, going from left to right. You'll see the highest decline from 1970 to 2010 in Toronto is in middle income neighborhoods, and the fastest increase has been in poor neighborhoods. There's also been some increase in rich neighborhoods. This is a trend that is occurring in all large cities. It's called the Manhattanization of our cities. It's been something that had been observed many years ago in the United States, and it's coming to a neighborhood near you. What we're seeing when we talk about the growth in chronic disease, non-communicable diseases, is happening most rapidly in the richest countries. That's the curve that's being projected going out. So we're going from a shift from sick individuals to sick populations, and that's why we need population health interventions. So what can we do? Well, first of all, don't believe, no matter how much patient-centered care is desirable and an important thing to move towards, we are not going to fix this one person at a time. We need population health interventions, and what that means is sometimes targeting care and sometimes making universal changes, and I'll talk about that in a second with my examples. First of all, and finally, we need to focus on prevention rather than improving treatment. It's like putting up a fence at the edge of the cliff rather than pouring your money into more ambulances at the bottom of the cliff. This can be fixed really well if we know where to put up the fence. So here's some examples. Dr. Kruger talked about increased smoking cessation, and reduced initiation means less lung cancer. So we have 3 lines here on the left. One is, all of them are showing reduced prevalence of smoking amongst the total population, which is in the middle, the top, which is male, and the bottom, which is female. What you will see on the right-hand side, however, is that though the prevalence of lung cancer has dropped for the general population and for men, it's on the rise for women. What gives? We don't know. Reducing death by car. You know, like we talk about health as something that we are in control of. Often things happen to us that we're not in control of. We have become very, very good at reducing death by car by introducing seat belts, airbags, speed limits, and also new ways that we are producing cars. So we know how to do population health interventions in this sort of instance. Your grandmother was right. An ounce of prevention is worth a pound of cure, and nowhere is this more obvious than where in dental care. So I'm showing you a chart here that shows how much we are spending per capita on dental care. If 85% of children aged 5 to 14 were covered in a school-based prevention program, which was what happened in Saskatchewan from 1979 to 1982, replicated in Manitoba, not driven by dentists, driven by dental technicians going to the school, providing primary care, and teaching kids about oral hygiene. If we did that, we would be spending about $560 million and saving about $4 billion $4 billion of our projected expenditures. We know how to do this. We know that we can fluoridate water, we can put in sealants, we can urge toothbrushing. There's going to be some sessions talking about this here. We know how to do this, and we must do it because where the rates of increase in dental care spending has accelerated the most rapidly is amongst First Nations populations, particularly Nunavut, and in immigrant populations in large cities. This is a function of poor nutrition, poor oral hygiene, and inability to access proper dental care in a timely manner. We also know that if we invest in human capital and if we start young, the returns on investment are going to be very large. We're going to be hearing about social returns on investment in a moment. So we know that the sooner we invest, the more we can reap the rewards. Here are the rewards for every dollar spent on these 4 different programs. $4.11 were returned on one program, $6.89 on another, $5.06 on another, $3.72 in another. These are all different types of early childhood intervention programs. We reap more than we sow if we sow early. We can also address segregation by neighborhoods and schools. You know, why are low-income neighborhoods low-income? Because they're terrible places to live. The schools are lousy, the transportation is awful, we don't have recreational facilities, we have lousy services. The housing is terrible in comparison to other neighborhoods. And where do poor people go? They go to low-income neighborhoods. So you get this kind of, is it in this slide? It's deprivation, magnification, amplification. It's a term by Jim Dunn. But we know that many of the schools in these areas, over 90% of the children populating them have got low SES, low incomes, low education to begin with. Their parents have low education. They're coming from already deprived families, and they've got 50% turnover. These families move around a lot. You cannot teach your way out of this situation. You need population health interventions. And in fact, education and housing are population health interventions. In fact, housing and health might be the best way, making interventions in housing might be the best way to flatten the gradient because it's the biggest bite out of everybody's income, whether you're rich or poor. As I said, low-income people live in the least desirable housing, wherever that is, and we know that homelessness is cheaper to cure than to treat. And the FCM, the Federation of Canadian Municipalities, has been talking over and over and over again about housing affordability being a major threat to the quality of life. Every year, in 2012, we let 1 million new people into Canada. Right? Federal immigration policy brought in 1 million economic immigrants, other family reunification immigrants, humanitarian, people coming in under humanitarian and refugee, and a flood of temporary foreign workers. These people have to live somewhere. There is no national housing policy. There is no national transit policy to deal with the congestion in the cities. Most people land in large cities and stay in large cities. We already had an affordable housing crisis. It's only going to get worse. So Housing First was just in the news yesterday. Less cost, better health. Let's do it. We know that it's if you leave people alone, compared to those receiving treatment and help through Housing First, we're going to have higher costs. The same story that Dr. Kruger was saying. Now, from a methodological point of view about assessing what is the impact of these measures that are not health care, fixing housing, providing more early childhood education, dental programs, all of these things, how do you know that these are the things that are going to improve health? We don't. We've got inadequate methods to assess these complex population health interventions, but the science, as I have watched on the advisory board of the Institute of Population and Public Health, that science is changing and evolving. We're getting better at identifying pertinent comparators to measure what is driving real change, and we know that we have to get better at measuring intersectoral action. It's not just or even primarily about health care, but every sector of health research views their different sectors as what is the most important type of evidence, and population and public health gets short shrift in these discussions. It's much easier to measure rates of cancer, for example. So there are these tensions in our system. I don't want to minimize them. There is huge tension between the desire for better individual care versus a collective approach to health care versus improving health. This is not part of our common parlance. We've been talking for 20 years about how broken the healthcare system is. It's going to take a while to change the conversation. Secondly, much public health work is done outside of the primary healthcare sector. One of the examples I didn't give you is all the fantastic work public health departments have done to control HIV/AIDS. No love without the glove. That would not have happened without public health work, but that isn't exactly healthcare work, is it? And there are competing demands from Canadians who want better health, but they also want more health care, and that's going to just keep accelerating. In fact, when we first introduced Medicare, we viewed access to publicly insured hospital and primary care services as one step. It was always viewed as we would have to do better work on home care, long-term care, mental health care, pharmaceuticals, dental care, vision. there's a lot of room to expand what we know works about Medicare, which is pooling risk and having early access to care. And there are some more tensions that are worth noting. There is a huge compatibility issue between cost effectiveness and health equity goals. So if you are looking at the science of how you measure the effectiveness of your healthcare, you can do the cost effectiveness work of Dr. Kruger's. Let us never forget that if you flatten the gradient, if you actually make those improvements of 1% more at the bottom where the highest risks are associated and flatten that gradient, you might be actually achieving more. And if you consider economics perspectives key, you may end up with very unintended consequences where you're putting much of the emphasis on the cost of the system rather than improving health, which will lead to reduced costs. So I ask you, what is our primary public policy goal? Is it to bend the cost curve or to reduce health disparities? Can we do both? Yes, we can, but politicians tend to favor one or the other, and it's very important to get the focus correct. I just want to indicate where I'm coming from. I'm coming from, as I said, the Canadian Institute for Health Research's Institute of Population and Public Health. The strategic health research priorities that we fund are pathways to health equity, population health interventions, implementation systems for population health interventions in public health as well as elsewhere, and developing the theoretical and methodological innovations, including economic evidence. By the way, this is the institute that is the most involved in the distribution of communicable chronic disease in global health, and we're learning as much from people around the world as we're developing in our own science here. So to summarize, I believe that more research, I bet you believe, that more research is needed. We don't know what we don't know. That's Rumsfeld's third postulate. Thank you. We don't know what we don't know, so we need more research and basic research, but more importantly, we need more action. We don't need more research before we start acting. Population health interventions are promising. We know that they are promising, so do more of them. Measure what happens, rinse and repeat. This is what science looks like. I want to just do a shout out for the people that are not in the room, but I couldn't have done this without them. There they are. My takeaway is we're not going to get out of this by doing patient-centered care. We need population health interventions, and that requires a focus on the social determinants of health, number one of which is income. So maybe if you want to fix healthcare, like Dr. Gary Block says, you need to actually help the poor be less poor. You can do that with money, you can do that through housing, you can do that through better education. You can do that by improving transit. You can do that by making more livable cities with better zoning. There's 1,000 ways you can do it, but income inequality and the impact of income inequality has to be addressed if you want to address the burden of chronic disease and prevent some of it. Thank you so much.